Good afternoon, everyone. Welcome again to the Dementia and Antipsychotics in a Long-Term Care Setting, a Quality Improvement Initiative web series. It's a partnership between Vanderbilt Medical Center, Vanderbilt Center for Quality Aging, and Q-STARS. This is our second in a series of 6 webinars. The full schedule is posted on the project website. And you should see that popping up in your chat pane right now, the link to that. At this point, we have all of the phone lines muted to provide a better listening experience. We won't be opening the phone lines during the webinar. If you have a question or comment, we ask that you use the chat box feature, and Britt will be monitoring that. Depending on how your screen's set up, the chat box will either be on the right-hand side or at the top of the screen. If you have questions or comments, post it there. And now, so we can verify that everybody can use the chat pane, please enter your facility name and how many people are viewing the webinar at your facility right now. We ask that you also fill out the attendance log that was attached to the invitation to this webinar. That gives us an idea of what type of staff are attending these sessions. It'll help us better tailor our future presentations to your needs. And also, while you're posting that information in the chat, I want to inform you that during today's presentation, you'll be asked to participate in some polling questions. So stay engaged. When you do answer a polling question, don't forget to hit the submit button so we can capture your answer. We have a very full session today, so we'll get to it quickly. Today's presentation is Alzheimer's disease and related dementias, characteristics, and behavioral disturbances. And we are lucky to have with us Dr. Paul Newhouse, who is the director of the Vanderbilt Center for Cognitive Medicine. He is a professor of psychiatry, pharmacology, and medicine. He's also the training director for the Vanderbilt Geriatric Psychiatry Fellowship. He has a great deal of experience also with consulting long-term care facilities on their use of antipsychotic medications. And at this point, we'll turn it over to him.
Thank you very much. Is there any way to validate whether everyone hears me? I'm hoping that everyone will hear me. So if you don't, please indicate on the chat window that you're not hearing, or if I say something that's obscure or confusing, please give us some feedback. So today's presentation has a few goals. We want to become familiar with the common dementing disorders and their clinical symptoms. We want to describe or be able to describe common behavioral problems in dementia. And we want to understand the context in which these behavioral disturbances occur in our patients, especially in the environment of long-term care. Okay, I'm being told here. All right, so we're going to start with a case. It's an unusual case, I'll say that, mainly because of the patient's age. So we'll start with a case. A 51-year-old woman, AD, is admitted to a long-term care facility because she's become unmanageable at home. Her husband reports that she has a loss of memory, she has delusions and temporary vegetative states. She will drag sheets across the house and scream for hours in the middle of the night. His attempts to manage this at home with the help of family and friends have been not fruitful. On examination by the admitting physician, she had a cluster of symptoms that include reduced comprehension and memory, as well as language disturbance, disorientation, unpredictable behavior, paranoia, auditory hallucinations, and severe social impairment. Despite treatment, her condition steadily deteriorated with memory loss, speech difficulty, confusion, suspicion, agitation, wandering, and screaming, and finally she became bedridden and incontinent and unaware of her surroundings. She died, and then her brain was sent for an autopsy by Dr. Aloysius Alzheimer. And this patient is actually Augusta Data. She was the index case for Alzheimer's disease In 1902, she was admitted to the Frankfurt Hospital for the Mentally Ill and died there about 5 years later, actually. And it was her brain that Alzheimer described the classic plaques and tangles that we associate with this illness. And I'm showing you this case because I want you to see that behavioral disturbances are at the core of this illness, and it hasn't been present from the beginning. Now, Augusta Data was a very unusual case, first because she was very young, and because she had some slightly dramatic or more dramatic than usual symptoms, and her tissue has actually been re-examined recently, and she has been shown to have a rare familial Alzheimer's gene mutation, PS1, which I won't get into talking about today, but suffice to say that she is one of those rare familial Alzheimer's cases. Now, of course, we know many more people that have developed Alzheimer's disease over the last few years that are prominent in the public eye. You can see pictures of Ronald Reagan, Pat Summitt, Glenn Campbell, Margaret Thatcher, Charlton Heston, and in the middle there is Barbara Smith, a famous model, was the first African-American model to be on the cover of national women's fashions magazines, and was a well-known restaurateur in New York. So Alzheimer's disease, which was actually named by Clayborn, refers to a neurodegenerative brain disorder regardless of status. And we can conceptualize this as having either of two stages, preclinical or pre-symptomatic. In other words, you have the biological propensity, but you don't know you have the illness yet. And then the symptomatic stages, where we consider it to be either prodromal or pre-Alzheimer's disease, which we now call MCI, or mild cognitive impairment, as well as dementia of the Alzheimer type. Now, what is dementia? Is dementia the same as Alzheimer's, or is it different? So dementia is a syndrome, and a syndrome can have multiple causes. We define dementia as a global impairment of higher functioning, including memory, capacity to solve problems of daily life, performance of learned skills, correct use of social skills, and control of emotions. And so, to be diagnosed with dementia, you have to have multiple cognitive deficits. You have to have memory problems, but you also have to have what I call the 4 A's, or the 3 A's, the other 3 A's, or Beige Fracture Agnosia, which refers to language, learned skills, and recognition. Or we perhaps include executive dysfunction in that, which means that I can't plan my day, or I can't decide what I'm going to do next. And so we regard this as diagnosing dementia, but this doesn't tell us what kind of dementia. Keep pressing the wrong button here. So if we look at Alzheimer's, and we'll come back to the diagnoses in a moment, if we look at what first symptom of Alzheimer's disease was noticed by the family members or by the patients, trouble remembering new information is by far the most common. At least half of patients or families notice this. Difficulty with complicated tasks is the second most common. Trouble responding to problems in the home, frequently getting lost or staying oriented is another common one, or trouble expressing thoughts or ideas or following conversations. Notice that changes in personality or behavior happen quite early in about a quarter of patients. Now, that's still not the majority of patients, but still we can expect changes in personality or behavior quite early on in certainly a distinct minority of patients. If we look at the timeline of Alzheimer's disease from prodromal to death, we can see that the average time is about 10 years. And the reason we know this is because when patients walk into my clinic, usually they've had symptoms for 3 years on average before they come in. And the family will, I always ask the question, when was the last time you had no worries about your mom or dad? And almost always the answer is 3 years. So 3 years plus some uncertain time in mild impairment, and then mild Alzheimer's disease moderate, and severe Alzheimer's disease usually takes place over an 8 to 10 year time frame. Some patients faster than others. Earlier patients tend to progress a little bit faster, people that have onset early in life. Later patients tend to progress more slowly as a general rule. So let's talk about the mild, moderate, and severe stages. I was taught once that everything in medicine can be divided into threes, and mild, moderate, and severe. So that's what we do here. In the mild stage, we see forgetfulness, difficulty learning new information, as we said. The patient may have difficulty planning her meals, managing her finances, or taking her medications in a regular way. Sometimes these symptoms are mistaken for depression, and we'll have more to say about that in a minute. But generally speaking, the patient has the ability to perform their ADLs, their activities of daily living. They're taking care of most things, although they might slip up a little bit. They might not change their clothes as frequently. They might be wearing soiled clothing. They might not have taken a bath recently, or they might get their medication confused. In the moderate stage, patients start to have short and long-term memory problems. They have difficulty performing more basic tasks, like using the shower appropriately or following written notes. They may start to experience behavioral symptoms at this stage, and they usually stop being able to stay independent. So once you reach the moderate stage of Alzheimer's disease, you really are going to become dependent on others to help you take care of yourself. You have deficits in reasoning. You might make poor judgments. You might forget your manners and say things like Donald Trump does, which are a little bit out of school, as they say. But that's not to imply that he suffers from dementia. But anyway, we lose perhaps some of our social judgment. In the severe stage, you become totally dependent. This is now the patient who may move into long-term care or institutional care. They may lose language functioning. Their speech may be unintelligible. Behavioral symptoms become common. The patient may not eat as well as they used to or cry out. They may fail to recognize their family or staff members, and they will need help with all of their essential activities of daily living, such as eating, toileting, or even sometimes walking. If we look at when people's ADLs change, Doug Glasgow had this nice graph back in the late 90s, and along the bottom axis is the mini mental state score, which goes from 30 to 0. And what you see in these green bars is the rough level at which patients start to have trouble with these activities. So keeping appointments tends to be troublesome right from the beginning. They start to have trouble with that in the mild stage. But dressing and grooming becomes more of a problem in late mild to early moderate, and walking and eating becomes evident really in the moderate to late stages. And so you can see this progression of losing skills and losing the ability to maintain oneself according to the cognitive level of the patient. Now, why do we try to diagnose Alzheimer's disease early as we can? Really, one of the major issues is safety. We want to make sure folks are safe, they're able to maintain themselves in their homes, particularly if they're living alone. We want to deal with family stress and misunderstandings, and we want to educate families and caregivers, because that really seems to impact how patients do well over time and whether they end up in long-term care early. We want to do advanced planning while the patient is still competent. We want to get wills and proxies and powers of attorney and advance directives taken care of when the patient still has the ability to understand them. And then, of course, we want to introduce early treatments as early as possible to try to make an impact on the symptoms and the course of illness if we can. Now, interestingly, Alzheimer's disease is often misdiagnosed. This is a study from the late 90s, but still, I think, valid today. when a patient with Alzheimer's disease was initially diagnosed, almost 3/4 of the time they were told that they did not have Alzheimer's disease. They were either told they had some other dementia, they were either told they had depression, or maybe they were just having normal aging. We're still dealing with that problem that a lot of people, including physicians, still think that becoming demented is normal, but it's not. And then strokes were sometimes misdiagnosed or no diagnosis at all, but you can see that only a little over 1/4 were correctly diagnosed right from the beginning. There are other dementias other than Alzheimer's disease that we see reasonably frequently, and I'm going to show you two. One of those is a diagnosis called frontotemporal dementia. This was actually described before Alzheimer's described his disease, and by Arnold Pick in 1892, and this is a particularly common cause of early onset dementia. And in fact, if you look at patients in the 40s and 50s, it's almost 1-to-1 with Alzheimer's disease. We extremely rarely or almost never see this in older ages. So these patients are almost always diagnosed in the 40s to 60s, and it's more common, or at least as common, as Alzheimer's disease below the age of 60. What's particularly interesting about this disease is the patients develop behavioral problems before they develop memory problems. It's the other way around usually in Alzheimer's disease. So these patients become more apathetic, they may become mentally rigid and inflexible, they commonly develop odd oral obsessions or obsessive compulsive type behaviors, and they may do perseverative and stereotyped repetitive behaviors that are the same all the time. And they particularly seem to develop odd oral obsessions. Bruce Miller has described emotional deficits in FTD, including lack of concern for loved ones' illnesses, cruelty to children, animals, or the elderly, lack of concern when others seem sad, rude comments or inappropriate comments to others, so-called disgusting behaviors, and diminished responses to pain. All of these would suggest frontotemporal dementia, which is really a different disease than Alzheimer's disease and does not respond to treatment in the same way. Another diagnosis we more commonly see is now called dementia with Lewy bodies, and this really seems to be a fusion of Parkinson's disease and Alzheimer's. The patients tend to have both Alzheimer-like symptoms and Parkinson motor symptoms. They have dementia, they have gait and balance problems. They seem to particularly have prominent hallucinations and delusions. The classic case that I remember seeing was the man who was brought to me because he had gone after those Boy Scouts in the backyard with a shotgun because they wouldn't leave because he was seeing Boy Scouts camping in the backyard constantly. And when people start running around with shotguns, people get concerned. Yeah. Neuropsychological tests don't reliably differentiate DLB from Alzheimer's disease, but pathologically we see differences, and they respond differentially to medications. They do respond to anti-Alzheimer drugs, however. They tend to have fluctuating cognition where they seem alert and then they seem out of it for periods of time. This is much more common in DLB. They have recurrent visual hallucinations quite early in the illness, earlier than Alzheimer's patients do, and they can look Parkinsonian, they can look slow, they can have muscle tone increases, and they can have tremors as well. Now let's turn to management. What is our management goals here with our dementia patient, our Alzheimer's disease patient? Our first goal is to preserve cognition and reduce decline. We want to maintain the quality of life. We can't always increase quantity of life, but we want to increase the quality of life. We want to maximize function and dignity. Dignity is an important component of what I think about. We want to treat mood and behavior problems when they occur, and we want to educate and counsel and refer families. Now, cholinesterase inhibitors are the mainstay of treatment of this illness. There are 3 oral drugs currently on the market. Although some patients experience improvement, most prominently they get cognitive stabilization. functional improvement may follow cognitive enhancement, and positive effects of these drugs do appear to be sustained, but they fade over long periods of time. And I'll just give you 3 illustrations. Here's a drug, one of the drugs that's on the market called galantamine, where they looked at the experience of the patient versus nursing home placement. And what they showed was that the patients in the red line, the one at the top, who had the longest treatment with galantamine, showed the slowest rate of admission to nursing homes, and it went down from there. And it's a very linear decline. The less treatment patients received, the faster they got admitted to long-term care. And so this is not a controlled trial. It's really more of a look back at experience, but it does tend to suggest that treatment early and treatment for a longer period reduces the risk of admission or reduces the rate at which people get admitted to long-term care. If we stop these medications, we immediately see worsening behavior. This was a study done in Great Britain where they openly administered donepezil, one of the other drugs on the market, and halfway through the study they took half the people off and put them on placebo blindly. And what we see is that their behavior scores get immediately worse. This is this arrow, this line here. This is worse is up in this graph, and patients get immediately worse when they get taken off the drug and put on placebo. And that doesn't get better, because after 3 more months, they're still showing worse behavioral symptoms. And so the idea here is that actually there is a behavioral benefit to being on anti-Alzheimer medication. And finally, this was a study done in late-stage Alzheimer's disease, in advanced Alzheimer's disease, that showed that even in late-stage illness, patients actually do better. Here is clinical improvement is up on this graph, and the donepezil-treated patients did show an improvement compared to the placebo-treated patients. Sorry about that, yeah. And didn't notice that one. But this is donepezil, which is now generic, and it shows improvement in behavior scores even compared to even in late-stage patients. So it suggests that cholinesterase inhibitors are valuable at all stages of illness. The effect size is not large, but the effect is very consistent. So let's turn to behavioral symptoms. Let's talk about what the phenomenology is. What do they look like? They're the most common reason for institutional placement. You don't get put in a nursing home because your memory's bad. You get put there because your behavior's bad, generally. Agitation is the most common reason that I get consulted for in patients in long-term care. And only 12% of patients in Jeff Cummings' study did not have behavioral problems. So almost everybody will develop behavioral disturbances. And it's the most common reason for why caregivers are distressed and stressed, including you folks in long-term care. If we look at this study by George Grossberg, what he showed was that if we look at the time before and after diagnosis, we can see when and how frequently behavioral problems occurred. So long before the diagnosis, the first signs seem to be social withdrawal and maybe depression, disturbances in diurnal rhythms, anxiety, paranoia, sometimes occur before the diagnosis, but not quite as frequently. You can see social withdrawal, depression, and sleep-wake disturbances occur very frequently. But after the diagnosis, then we begin to see irritability, wandering, aggression, and notice hallucinations are fairly late in most Alzheimer's patients. So some behavioral symptoms tend to occur usually before diagnosis in months. This is in months, actually, versus some change after. And so you're dealing in long-term care more with this side of the slide. Common behavioral symptoms I'm going to touch on today include apathy, which means decreased motivation and indifference, disrupted mood, either depression or mania-like, psychosis, including paranoia and visual hallucinations, agitation, anxiety and psychosis, aggression, loss of impulse control, and wandering, which we interpret as searching or disorientation. So let's touch on a few of these. Apathy is the most common behavioral change. It means decreased motivation or more indifference. It means someone who doesn't have goal-directed behavior. They may just sit. It's not necessarily related to depression. It is true that depressed patients are apathetic, but not all apathetic patients are depressed. And so we see apathy in dementia patients without depression, and so we can't always interpret that as a depressive symptom. Psychotic symptoms are very common. In cross-sectional studies, up to 50% of patients at any one time will have some psychotic symptoms. Longitudinally, if you follow people, up to 70% will have psychotic symptoms. And most of these are delusions with some hallucinations. Common delusions include theft, infidelity, delusional thinking that a spouse or family member is someone else, what we call the phantom border sign. I have people living in my house. In Vermont, it used to be either men or children living in the house when I was living there. Hallucinations are also common but tend to be visual rather than auditory for the most part. This is different from schizophrenia, in which the hallucinations are more commonly auditory than visual, but there's some overlap there. So hallucinations tend to come and go. Patients with dementia also have the belief that one's belongings have been stolen, the conviction that one is being persecuted, and having spousal infidelity beliefs are fairly common and can be quite actually damaging to family relationships. Mood changes are frequent and may be secondary to impairment of circuits in the brain that regulate mood, what we might call emotional incontinence. The patient can't control their sadness or their happiness anymore. Actual major depressive disorder or full-blown depression is relatively less common, but we do know that depression can precede the diagnosis of Alzheimer's disease, and we believe that patients with late-life depression are at higher risk for developing dementia, and in fact, that's an area that we study. Agitation we define as excess motor or verbal activity that's disruptive or unsafe, distressing to the patient or those around him or her, interferes with care, and is not necessarily because of need. Unfortunately, it appears similar despite a great variety of causes, and this is oftentimes what nursing staff will label when they call something behaviors. That what they really mean is agitation. And one of the things you're going to see in the seminars to come is how we have to really drill down on agitation to understand both its root causes and the best way of ameliorating it. Agitation tends to correlate with anxiety in mildly demented patients. It tends to correlate with psychosis in moderately demented patients, and it correlates with breakdown of all these brain systems that regulate behavior in severely demented patients. We know much less about why severely demented patients become agitated, but we think it's related to the fact that these circuits can no longer work to control emotional output. Sundowning is a term that's used fairly frequently and is really just a way of saying agitation associated with the late afternoon or evening. We think that the causes related to so-called sundowning are fatigue. We know that there are circadian factors. The brain and the body have a 12-hour circadian rhythm, and late afternoon is one of the low points along with early morning for circadian rhythm. And we know that all of us become more tired in the late afternoon, and it's not surprising that if we have a brain disease, we might tend to become more upset or anxious. Need for security and protection may also play a role in this as well. Wandering is a common behavioral problem that relates to disorientation, confusion about where one is, the need to go home, restlessness, searching for something or somebody. Obviously, sundowning can be a cause. Fear by itself can lead to people wanting to wander, or medication-induced wandering or pacing can also play a role, so-called akathisia, which means basically the need to move. And so we want to look at all the potential reasons for wandering and ways to ameliorate that don't involve necessarily sedation. Aggression can be a real problem, especially in long-term care. It can be in response to the environment, or it can be spontaneous. It can be verbal and physical, or physical. It can occur with or without delusions or hallucinations, and sometimes it may be resistant to conventional pharmacotherapy, and we have to think of new strategies, and we'll have more to say about that and how we treat that in future seminars. And here we have a polling question. Which of the following is not a common behavioral symptom in Alzheimer's disease? And do I read them?
Sure.
And so your choices are apathy, psychosis, aggression, shaking, fear, or anxiety. And you choose an answer from the box and click submit at the bottom, and we'll total up the scores and see if anyone's still paying attention. All right. So I give them a minute?
Yeah.
All right. Okay. All right. Oh, it looks like no answer was 5, and 12 people voted for shaking. That was a good answer. Great. All right. Okay, we'll move on. For those of you who have answered the question appropriately, you get, an extra star. Let's look at why problem behaviors occur. Now we've described some of the phenomenology, but why do some of the behaviors that we see on long-term care occur? We touched on some of them: fear, disorientation, confusion, overstimulation, lowered frustration tolerance, loss of impulse control, meaning I know what I should do, but I can't inhibit the impulse to do something else. Inability to recognize who family and caregiver are. We've talked about disorientation, disrupted routines, and finally, just forgetting what an appropriate behavior is. If a man urinates in a wastebasket, it may be that he doesn't recognize that that's not the toilet, or if he disrobes in the day room, he may have simply lost impulse control. I like to look at the context of behavioral problems, the personal, the environmental, and the chronological. The personal context is, how am I feeling today? Do I have pain? Do I suffer sensory loss? Might I have an infection that causes more confusion? Or am I suffering from psychotic symptoms? All of those may impact whether I express that behavioral problem. I might also want to look at the environmental aspects of this. Did the patient or the resident just get transferred, either to the hospital or back from the hospital? Did the family visit and create distress for the patient, or just leave and create distress? Is personal care and bathing a particularly troublesome time? That's an environmental context. And finally, even the giving of medications can be difficult and problematic. And finally, we want to look at the chronological context. Are there certain times of day which are more difficult than others? Is waking up or awakening a particularly difficult time? Meal times might be more problematic, especially if a patient perhaps eats in the day room versus by themselves. Is the late afternoon a time when she gets agitated? Or how about when the patient just won't go to bed and spends her night or his night wandering around the unit? Those are all chronological aspects of behavioral problems, and we want to look at, when we analyze this, we want to look at the personal, the environmental, and the chronological. So let's look at proximal factors for each of these. Does the resident have unmet physical needs? Are they suffering pain? Are they thirsty, hungry, or tired? Have they not been able to sleep, or are they having medication side effects? Are they sensorily impaired? Do they need to use the toilet? Are they constipated or incontinent? Are they in need of some physical problem that needs to be ameliorated? We need to look at those first. What about psychological needs? This is something that we don't do a great job of in long-term care. People can be lonely or bored. One of the most biggest problems, I think, in long-term care is simple boredom. There's not much to do. If you can't generate your own activities, if you're suffering from dementia, you may simply just sit and be bored. Apprehension, fear, and worry can be a psychological factor. Maybe the fact that your roommate is screaming leads to emotional discomfort. There might be less in the way of enjoyable activities, or maybe your family doesn't visit you very much, or can be disruptive when they do. And finally, loss of intimacy and dignity, I think, are huge psychological factors. I think the maintenance of dignity is a key issue for many patients, and I think that we all need to pay attention to the necessity to maintain elders' dignity even in the late stages of illness. What about environmental and social factors that play into it? Is there just too many people and too much noise in the environment that contributes to behavioral problems? This is, I think, a common problem. Is there a blasting radio that's blasting out country music when quiet music might be better for everyone? Is it just too noisy a place for people to be in the day room when they're distressed? Is there too little to do? Are our expectations for performance too high? Do we expect people to be able to do things or maintain control of their behaviors when they can't, really? So, for example, if we have a sexually disinhibited patient, I've had nurses and staff tell me, well, he knows what he's doing. Well, but my answer to them, of course he knows what he's doing. That's not the point. The point is you can't expect him to control that behavior because of the damage to his brain. Communication might be unclear, and finally, we don't adjust our caregiving to the level of the patient's ability and needs. And so we have to look at all of these particular factors. And finally, the physical environment around you. Maybe, if I'm in a big crowded place, I might be confused. I might not understand what's going on. Are the TV, radio, PA systems confusing? If I tell you I'm hearing voices, maybe I'm hearing voices because I hear a disembodied television constantly running, and I don't see anybody, so I translate that into people. Are pictures and photographs or even reflections misunderstood? We've had patients confuse photographs of family members for real people and get confused about that, and we've had to actually remove photographs occasionally because they become too confusing. We've had patients actually demand that this person in the photo is in need of help and we must help them right now. Perhaps signs are confusing or cues to wayfind are not there. We might lack natural walking paths or daily exercise. Exercise really is important. Physical activity is important. We'll have more to say about that when we get into later seminars, but the lack of ability to have physical activity, I think, is a big contributor to behavioral problems. And finally, of course, causes related to other psychiatric illnesses. Having dementia does not protect you against a lifelong history of other illnesses. Patients may actually suffer from treatable depression, anxiety, even delirium, or other mental illnesses. If a patient has suffered schizophrenia or bipolar disorder, you can expect that will complicate any dementing disorder that's happening overlapping with that patient's chronic mental illness. Delirium, we'll just say one word about it today. Delirium is an acute brain state that's on top of anything the patient may already have. It can usually be a sudden change in behavior. That's particularly suggestive of delirium. It's usually acute or comes on quite quickly. The patient may have an altered or fluctuating level of alertness. And I tend to look for infections, new medications, and any medication that's particularly anticholinergic. And of course, the most likely person to become delirious is someone who has dementia. And so that is the most likely patient to suffer from delirium. And we have to always look for this superimposed syndrome whenever patients have an abrupt change in behavior. And we have a polling question here. Abrupt changes in behavior, this is kind of easy to get. Abrupt changes in behavior in a previously stable patient with dementia may include delirium, infection, metabolic disturbance, drug interactions, or all of the above. We'll play a little tune for you while you make your answer. If you get this one wrong, I'm going home. All right. Let's see how we did. And the answer is, everybody got the right one. Excellent. All right. Close that window. Oh, another polling question. Okay, agitation should be assessed for causative factors to successfully treat. Yes or no? True or false? Go ahead. Everybody got that right. Good answer, all you people, especially the ones that didn't give any answer. You're careful, I can see that. So let me summarize here. First of all, dementia is a syndrome. The most common cause is Alzheimer's disease, but that's not the only cause. Other dementias with behavioral disturbances include frontotemporal dementia and Lewy body dementia, and we haven't covered it today, but also vascular dementia. Behavioral disturbances are a core feature of dementia and can be expected in most, if not all, patients. The context, the environmental, the personal, the physical, and the psychological, will often determine whether and how behavioral disturbances are expressed. So who you are, where you are, and what you are, and who's around you will often determine this. And when we want to understand an effective way to prevent or treat these problems, we have to look at those contexts. I'm asked to point out that there will be a second presentation of this session, so if you want to come back for another run through this, you can do this on Wednesday, November 18th at 10 a.m. At Central Standard Time, and so we'll go through this once more. And we're going to have session 3 in December, after Thanksgiving, where we will have psychopharmacology in the nursing home, where we will cover what psychotropic drugs are used commonly in the nursing home and how they should be used and not used. December 15th, Tuesday, 1 p.m., and December 16th, Wednesday at 10 a.m. are your dates for those seminars. And I have listed here a number of contacts for further information I don't know if everyone gets these slides, but they can probably look at them on the website at vanderbiltantipsychoticreduction.org, which is a mouthful. And you can contact Emily Hollingsworth or Brittany Kurtz through email at vanderbilt.edu, or actually check the Vanderbilt Center for Quality Aging for other resources. We're going to have additional resources for you in upcoming sessions as well. And so your Christmas gifts are coming. And now I'm told that we can open it up for questions, and hopefully this has been helpful to you. And I guess they come in as chat, right?
Yes.
Okay. And I will hang on here.
While you're sending us your questions, if we can have WebEx, please put up the last polling question, the evaluation question.
Ask a question?
Yeah, sure.
I would like to ask a question of the staff that are attending this. How significant are behavioral problems in dementia patients to your facility and professional activities? Are they very significant, not at all significant, or somewhere in between? I'd be interested to know how much of a problem folks see this as at their facilities.
Extremely significant from Karen Parker. One explanation point.
All right.
Very significant. Zero words.
I think, so several of you have said that these are very significant problems, and I do agree with you that this is the most challenging in many ways aspects of dementia, which is how do we deal with these behavioral problems. And I salute you as the staff of these institutions for your commitment to managing these very difficult and challenging behaviors and patients, and I'm always deeply impressed with the folks that I work with in long-term care in terms of their commitment to really handling some of the most difficult jobs in medicine. So I appreciate greatly how challenging and frustrating this can be to all of us who really want to help our patients have really good quality of life. If there are any questions that you have about what I've presented so far, I'm happy to answer them as best I can. And if you have follow-up questions and you're just shy about typing, please send them to Brittany, and Brittany will pass them on to me, and I will make my best stab at answering them. I will be back with you in some of the subsequent seminars to discuss how we assess behavioral problems and how we can deal with them. And we also have a great team here that's going to also work with you in terms of providing new and exciting strategies and approaches that I think will help you become more confident and more expert in your handling of these illnesses and behavioral problems. All right, last chance here to get your additional questions in.
And the evaluation question will be open for another minute.
Your last chance to vote me off the island.
We would also encourage you to share the project website and the slides with other staff within your facility who may not be able to attend the webinars. We recognize that there are a lot of staff involved in caring for these residents, and you can't necessarily pull multiple people simultaneously for one of these time slots. So feel free to share the project website with as many staff in your facility as possible.
And please feel free to use these slides to do your own in-service education. So we're making these available to you, and feel free to use them.
Just a reminder, if you have other staff you want to view this session live, we'll be redoing it Wednesday, November 18th at 10 a.m. Central Time, 11 Eastern, and the dates for all the sessions are available on the website. So if we don't see you then, we'll see you in December. Thanks.